I'm a consultant neurologist based within one of the group chain models and also Managing Director of the Academic Health Science Network within UCL Partners. So I'm going to take you through a few preliminary slides, then discuss quite briefly about what the acute care model looks like, and then we have a number of panellists that I'll introduce you to shortly. So we have a number of chat box monitors, so really important that you're trying to contribute throughout today, and we have Karen, Miranda and Carly who are going to be monitoring the chat boxes for questions, and then we have Dominic and Dom who will be using the Twitter feed. So please remember to use the Twitter handles that have been provided, and so that we can get your questions there. We are going to be joined by Jacob West later on in this session. Jacob's the national lead for the acute care collaboration model. At the moment, we have, I believe, Sarah Morgan, who's Director of Organisational Development from Guy's and Tommy's, Tim Taylor, who is Consultant Radiologist in Nottingham, Stuart, Director of Strategy and Planning at the Walton, and Junaid Bajwa, who's one of the Clinical Associates within the new care models within the programme team. So, if you're joining us today, as well as using questions through the chat box, please use the hashtag FutureNHS to share the discussion so that we can get people joining this and posting comments and questions. And then when we've recorded this, we're going to produce a short story summary for everyone to download later on. So what I'd like to do, first of all, I'm very aware that we've got many people joining the session today and different levels of knowledge about what Vanguards and the acute care model is all about. So if I can get you to go on to the pencil icon and then to take the pointer and then to mark where you think you are in terms of your knowledge base, with 1 being that you know very little about it and 10 being that you know a lot. So, just to give you an example, some people being quite creative with the black marker pen, which is absolutely fine. I think with a lot of these sessions, a lot of people start to join us through them. So, just to put a mark of where you think you are within the programme, that'd be quite useful. Okay, we'll give that another few seconds and then we'll move on. The other thing that we'd like to find out is which sort of organisations that you're most likely to be affiliated with. So again, if you can mark whether you're working within a Vanguard team or whether you're linked to an organisation such as an improvement organisation or an HSN, whether you're interested in one of your organisations about setting up a new care model or indeed just learning from the ones that are already established. Okay, thanks for that. I think we've got reasonable representation from across different areas. So if we try to think about why acute care collaborations were set up and what they represent, so this is part of the New Care Models programme, and there are 13 acute care collaborations around the country, which were selected slightly later than some of the other new models and selected towards the end of 2015. And of course, this initiative essentially came out of some of the work from the 5-year forward view that talked about new models of care, about trying to improve standards of care for patients. And the idea was also formulated in part of the Dalton strategy that came out after that. And then I think in terms of focus about what the need is within acute hospital settings, very useful document from Lord Carter that came out towards the end of 2015 that identified a number of areas that really were important in helping us to try to meet the financial deficit that the NHS and the acute care system is facing. And so, based on these strategy documents, a number of the acute care vanguards were selected, and we have a number represented in the slide here that both covers the geography of the country, but I think subdivides into a number of different groups, and in essence you can, I think, sort of divide them into two specific groups. One that focuses around institutions or hospital chains, or ones that are much more specialty specific. So within the chains, we have hospitals, for example, such as the Royal Free, that's created a group of hospitals that come together within a large geography across north central London. Then we also have examples that focus much more on specialist hospital services around a particular individual clinical need. So that, for example, might include Moorfields Eye Hospital, looking at chains of hospitals that just focused on eyes and vision, or orthopaedic chains, or indeed the Cancer Vanguard, which takes in 3 geographies across 2 parts of London and Manchester. And then finally, what could be described as accountable clinical networks, which try to integrate key services across district general hospitals. And I know that the East Midlands Radiology Consortium would fall into that group. So what are the sort of different benefits that we might expect to see from the different models that have been set up? Well, I think, from a clinical perspective, the most important thing that we see is that we want to share best practice at scale. We're all very much aware of people setting up good initiatives or improvements that happen either in a pathway or in a ward, or even sometimes in a hospital setting. But the difficulty is that doesn't often translate, and the shared learning doesn't pass across the system to really capitalise on the value there. And so I think sharing best practice at scale, being able to co-produce, and I think co-production, both at setting standards and then identifying what's important, both for the patients in various pathways, but with health professionals and clinicians that are delivering that care, co-production is very important. There are clearly the benefits of scale that can be leveraged by procuring jointly across multiple organisations, and also you can share services together. So sharing corporate services or sharing clinical support services both has the potential to improve quality across multiple organisations, but at the same time has the capacity to reduce costs. And I think also by bringing individual organisations to work at bigger scale, that's also more attractive to industry partners who can see the benefit about having a single conversation with multiple organisations rather than just have conversations individually with lots of different providers. I think in terms of workforce challenges, which I would say are one of the biggest challenges that we face within the NHS and healthcare, what initiatives like this allow us to do is to really invest in leadership, and certainly the Royal Free, where a leadership academy has been established. This can allow people to develop new skills, both in terms of improvement and in coaching, bringing in different leadership styles and ways of working, and then bringing in other things such as innovation. The collaborations will take multiple forms, and if we look at this matrix, it really goes from what are essentially a much more simple single service collaboration down in the left-hand side of this matrix, and will work in different ways, building up to different levels of sophistication, to ultimately the most sort of consolidated and most sophisticated models, which could either be in the form of an accountable care organisation or maybe in a hospital group. And we'll hear from some of the panellists about the different ways of working that have been established in a couple of the vanguards that are up and running at the moment. So what we're going to do now is to turn to panel discussion and to bring in some of our panellists to hear about some of their experiences in the model that they're delivering. But it would be really good to get your questions both through chat box and please tweet through the hashtag #FutureNHS so we can get an index of what you think are some of the main issues here. So perhaps I can turn to Tim Taylor from Nottingham University first. And Tim, perhaps you could tell us what you're doing in your new model and what you've delivered to date.
Yeah, certainly. I'll just check you can hear me?
Yes, I can hear you very well, Tim.
Excellent, good. Yeah, so I'm a radiologist by trade. I'm the medical director of the MLab consortium. Now that consortium is 7 NHS organisations holding 7 separate technical contracts with a technical service supplier who've chosen to work together in collaboration. And they are not held together by anything other than their desire to provide a shared service for benefit of patient care. So we fall into one of the very federation stroke alliance or consortium models of a multi-service collaboration without the need to go into a corporate joint venture or anything more complicated, so we found. And we've spent the last 4 years working together, 2 of those as the Vanguard organisation, exploring just exactly what we can do as 7 trusts together that we couldn't do as 7 trusts individually. And what we found actually is the first thing we can do is we can start to trust each other and we can start to be open and honest with each other about the scale of our service difficulties. And we can start to break bread and have coffee together rather than immediately distrust each other and consider that the hospital down the road is out to get us or that we're going to get swamped with clinical activity.
Well, I think that trust issue is absolutely fundamental, particularly where there have been relations and working practices going back many years which have not always been as positive. So yes. Thank you for that insight. Perhaps I could turn to you, Stuart, and ask you the same question about what you're doing in your new model and some key areas where you think you're delivering.
Yeah, thanks, Charlie. We are, from our Vanguard, we're hosted in a specialist neuroscience centre and we're focusing on 2 service areas, neurology and spinal services. And I think neurology gives a nice example. We serve about 3 million people across a wide area in North West England and North Wales. For neurology, it's a small specialty and it's really hard pressed by growth in demand, and it's not something that can easily be provided across acute hospitals. So we already provide neurology outreach in terms of satellite clinics and ward consultation service across all of the acute hospitals. And what we're backing that up with through the Vanguard is through a more integrated service all the way through from primary care, so support lines, pathways for primary care and for hospital clinicians, additional support for patients at home, and some key community-based new advanced nursing roles to really provide the connectivity between patients at home, GPs, community healthcare teams, and even when the patients are in the acute sector, linking back to the regional centre. And what we're finding from that is that there's much more joined up care for the patients, and it's able to, in many cases, to be able to discharge patients from the acute or avoid admission from the acute through the support and advice and pathways that have been provided into the A&Es.
That's great, Stuart. Thanks for that summary. Perhaps I can turn to Sarah now and to get a brief update from you about what you're doing and what you've achieved.
Hello, yes, can you hear me?
Yes, very well,
yeah.
Sarah.
Just checking the technology is working. So we've been working very closely with Dartford and Gresham and at two levels actually. So both at a clinical level, so we have clinical pathways in cardiology, paediatrics and vascular, but also at the top of the organisation. So we've come together in a committee in common which has equal representation from the executives of both organisations. And I think similarly to what Tim was describing there, actually the trust that we've built up has been a really key part of what we've done. We've spent a long time thinking about what's the vision and what are we trying to achieve. But what we've experienced is that's enabled the clinical teams to feel permission to move things forward quite quickly, knowing that they've got the support and there's, you know, we've had some teething problems with IT and different things that happen, but actually that commitment at the top of the organisation, so the chief exec and medical directors, has really enabled those clinicians to move further faster.
Thank you very much, Sarah. Junaid, I wonder if I can bring you in at this point. I mean, obviously you're attached to the New Care Models programme, so you get an oversight of the different models. I'd be interested in what your perspective on the acute care collaboration is and, you know, what the challenges are. So it doesn't look as if Junaid is with us currently.
Can you hear me?
Well, yeah, I can hear you now, Junaid. That's great.
Oh, sorry. Just by way of brief background, so GP by background, but I've had a chance to work across the payer side, the provider side, and the regulatory side, and it's quite interesting kind of seeing this bird's eye view and seeing how lots of different groups are tackling similar problems together. I think historically we've focused on solutions and then we're trying to retrofit in problems, and where I think the more of the success I've seen is where people have gotten together and there is trust, but they've clearly articulated the problem that they are trying to solve and then go to solve that problem together, and then quickly realizing that there could be others that they could learn from who have tackled the same problem, and so they don't have to make the same mistakes and they can leverage that. My specific focus has been around digital and supporting the digital transformation side of things. And we can really scale these things in a better way than what we do today, but we can leverage the NHS's Innovation Accelerator, the Clinical Entrepreneur Program, the variety of different things that other new models of care have done either historically or currently, and bring them in to the benefit for the ACC model as well.
Thanks very much, Junaid. One of the aspects that came out of the Carter review that I think certainly resonated with me was that, you know, delayed transfer of care out of the acute setting is not only bad for patients, it increases the risk of complications from prolonged stay. Also, of course, adds substantially to loss of income for organisations. And I was interested to hear from our panellists about whether there's specific initiatives that they're involved in with addressing delayed transfer within their collaboration. So perhaps I could start with you again, Tim, on that.
Yep. So delayed transfer is an interesting thing because as a radiology service, pretty much everything hinges on us at some point, even if we don't want it to. However, it's very difficult for us to directly impact a delay in a transfer of care, or very difficult to unpick why exactly we might be involved in it. As with many acute care organisations, our processes are multifactorial, and it's really, really difficult to prove a demonstrable benefit from a small or a single intervention. Rather, what we're finding is that making 1 or 2% changes here and there are starting to help significantly in terms of patient flow, which is the other big thing. And again, looking more regionally, it's not so much about one organisation, it's more about how do we sustain and how do we help sustain a clinical service in a geographically disparate region, which in our case is about 8% of NHS England's whole population base. So less about patient transfer and patient motion, more about service provision.
Yeah, although it is interesting, and certainly in many hospitals that I've worked in over the years, that actually waiting to have radiological investigations done and reported and actioned on can contribute quite significantly to delays in discharge, for example, or to transfer. So I'm sure that there are pieces of work that can be done there to learn from.
So it's a challenge. I'm going to come back on that one. Yes, there are, but the challenge to say if we make it faster, we make it better. It's not so much can we make it faster, it's how can we support the people making that service work when they're already exceptionally constrained and working within an economic and healthcare environment that is hammering them to pieces at the moment. Yeah. So you could say, how do we demonstrate improvements? Well, I would equally counter, how do you encourage people to think that where they are is a great place to stay? And how do you support them in what is a very difficult clinical situation? That's just as important. Yeah, okay, that's a fair point. Stuart, do you have any views on this about delayed transfer of care from acute settings within your work?
Yeah, I mean, I wouldn't express it as delayed transfers of care. I mean, I think in terms of our model, what we're really about is finding the best way of helping to move patients through their pathway within the acute hospitals. So you're not going to, one is not going to be able to provide a 7-day neurology service in every acute hospital in the country. You can do it in a neurology centre, but not in every acute hospital. So from our point of view, it's making sure that we're not becoming a source of delay because of the amount of coverage across the week that we can provide. So as part of our Vanguard, we're stepping up and systematising a consultant advice line so that our on-call consultant, our 7-day-a-week on-call consultant, is available to provide advice remotely to the acute hospitals. And also we've started piloting teleneurology, remote video consultation in one of the acute hospitals, which we're looking to roll out across. So it's about making sure that it's less the tackling the delays in the discharge. It's more about the delays in the pathway as we go along, because we recognise that where you've got a scarce resource, that's always a pinch point for helping to move patients through.
Okay, that's great. Stuart, Sarah, what are your views about how you get?
Sorry. So I think we're quite similar to the things Stuart's just described. So we have a few things that we've been doing which are not technically delayed transfers of care, but improve the pathway for the patient. And one of which is what we call a proactive older people service, which is how do you optimise patients who are comorbid and elderly prior to surgery. So we are the hub at St Thomas's, the vascular surgery is done there. And what we were finding was patients were coming from Dartford, but were waiting in beds at St Thomas's to be optimised, ready for surgery. And now we've got a service that is down in Dartford, the patients are optimised, and to the point where instead of going back to Dartford, they can potentially go home. And I think that's part of how we work together along the pathway to improve that. And the other thing is a similar line. So again, we have the specialists, and actually what's important is the access to specialist opinion, because actually sometimes it's just a quick call, or we've been running experiments on with our cardiology teams on Skype for Business, actually having virtual MDTs. So I think that it is for us, it's streamlining the pathway, and we've started paediatric epilepsy clinics down in Dartford, so that actually patients aren't coming up to London and it's done all in one place. It's trying to strip out all those delays in the pathway and create a better pathway for the patient that's in our focus.
Okay, thanks for that. Before I go on to some more questions, it'd be good to know from our Twitter monitors and chat box monitors if there's any specific questions that are coming up from the audience that they're keen to explore. So we'll wait we'll wait for that. I mean, I think the other area, of course, that people are very keen to see is that it's nice to see that the systems are up and running, but what we also are keen to see is what you see as the future for the model and how it expands. Tim, can you talk about the future planning for the acute care collaboration that you're running?
Yes. So it's really, really interesting when you think about how big can you go and what's the point of going big, and how far can you spread. What we seem to have found is that the model that's working for us with Vanguard is not based on technology or information technology. Anybody can do that, and many of us do. Many of us have been tripped up by that in the past, and aiming to put the saviour of the modern healthcare service will be IT. I say that as a geek, but actually it's not true. The saviour of the NHS will be the people who provide it because they think it's the right thing to do.
Yeah.
And what we're really excited about is going into places like, for example, Vivo Manchester, and spending a day with them and saying, look, actually, the things that you consider that might be excuses to working collaboratively aren't really blocks at all. And when you get rid of those, which is what we've had the privilege of being able to do in MRAD, just do the heavy lifting and get rid of the blocks, you come down to the fundamental of why don't you trust that person? How can we help you trust each other so that you can provide services to patients across the traditional boundaries in a horizontal model? And that really excites me. The untapped potential for that is just let people do what they need to do because it's the right thing to do is why I get up in the morning.
Yeah. Well, that's great. Thank you for sharing your excitement with us. We'll move on to Stuart. I mean, it'd be useful to hear from you about how you see the future of your model developing.
Was that Stuart or Sarah?
That was Stuart first.
Yeah, I think where do we go now? I think the thing for us is going to be about how we make sure that we book the models into that whole landscape. So what we are focusing on in terms of the introductory slides, Charlie, is we're kind of quite at that sort of single specialty or a couple of network model. But in our patch, people are developing accountable care organisations, people developing locality models and so on. And we feel that our model can hook into those very well. But what we need to make sure is that we're kind of participating in the right conversations to so that things don't go off on the wrong track.
Okay, thank you for that, Stuart. Sarah?
So I think I'm in this is really exciting camp like Tim, because for us, although we're an acute care collaboration, obviously the foundations for us are also we're a combined acute and community provider. So could this be a way of us thinking about collaboration both vertically as well as horizontally? So that's something that we're really thoughtful about. And also the other part of this is the replicability and scalability of it. So, you know, at the moment it's our relationship with Dartford and Gravesham as a founding member of the group, but actually what else could we achieve if there were more members, and we scaled some of the work we've been doing on standardisation and thinking about actually how would we drive efficiency across more members. And so that's how we take that to the next level, and really thinking about collaboration as the key to it, and coming together on a shared ethos and a shared vision. So what are we trying to achieve as the group? Is it we're trying to improve clinical outcomes for the population we serve? Is it that we want to drive standardisation? So, and we haven't quite got to that yet. That's our next phase of work, but I think it's really exciting about its potential.
Yeah. Junaid, I mean, it'd be interesting to get your perspective more broadly on new models of care. I mean, where do you think it's going to head? I mean, if you were to predict how it's going to evolve over the next few years, how would you see it working?
So I think where we are today, it's definitely much more around building the mindset, building that notion of community, building that notion of collaboration. I think what we've done is we've done a lot of really, really good work, but we still keep these silos, especially across, say, mental and physical health, as an example. And just as you were talking about delayed transfers of care, one thing that I was reflecting on was there are a few vanguards that are saying, well, is actually discharge the right word? If you ask patients, do they feel that they've never been discharged from a system Actually, they never have. And what mental health organizations talk much more around is the recovery plan. So should we be talking much more around the notion of recovery? And if every patient had a recovery plan rather than a discharge plan at the point of discharge or at the point of the next transition of care, what would that do to the mindset and how we would work and operate? So I think if we spend, and I think quite rightly we spend a long time on the language and quite rightly spend a long time on the community, moving forward, if we can get the finances right, the procurement right, and how we do things using technology for a particular focus, such as how do you enable self-care across populations and what is technology's role in enabling that, I think we have a lot of assets, a lot of really good rigor that we can apply. And moving forward in the future, we will use data much more intelligently than what we do today to enable improvements to be made on a continual basis for emerging models of care.
So thank you, Junaid. I mean, so you talked about the importance of data, and I suppose that takes us, I think, quite smoothly onto the issue about information governance and the use of data. I'm interested to hear how each of your vanguards are doing that and how you've managed to share information effectively. Tim, can you give us your insights into that?
Yeah, we have an awful lot of information governance issues, as you might imagine. So just for those on the call, the MRAD technical system has 1.6 billion images in it relating to 6.5 million patients. You can imagine that the information governance of I would like a doctor or a nurse in one trust to see anything that they have a legitimate interest in, that could have been a major stumbling block in what we did. But actually, we found that it isn't. It isn't nearly as much of a stumbling block as is often described, as long as there is trust. And so from an information governance perspective, we've found that it's actually very easy to share information within NHS organizations and across NHS organizations, as long as the organizations agree to formally trust each other, and we get that in writing. And effectively, we made our organizations joint data controllers for the entire region. Again, not under contract, but from an IG perspective, if something goes wrong in one of our organizations, all 7 organizations are on the hook. It's amazing how that focuses the mind and drives up standards. It's a very simple thing to do, but fundamentally, once that step was put in place and people went, yes, this is the right thing to do, it really helps to drive every other process forward. So IG is crucial, but it's not the barrier that it's often described as.
Okay, thank you. And Stuart, how are you finding sharing information governance working? Maybe I'll move on to Sarah then, if Stuart's not connected at the moment. Sarah, can you give us your insight into that?
Yeah, so we've got it at 2 levels. So both our boards signed memorandums of understanding that has information governance specifically set out, and we sign those in public. And we also have it at the level of our clinical teams, which has been agreed by both our information governance teams. But it's slightly easier in terms of it is a pathway between the 2 organisations. What we also have across what's called King's Health Partners, which is us, King's College Hospital and SLAM, is a shared access to a shared record, which we call local care record. And the next stage for us is rolling that into Dartford, as they refer to both King's and ourselves. So actually just working through how we do that, because that's incredibly beneficial for their consultants to be able to see what's happened with the tertiary referrals. So, and again, that comes down to trust in what we've been able to do as King's Health Partners, and that coming together, I think, really does mean you can move things forward quickly, and so that's how we'll do it. Tim distracted me with his little note then.
Thank you, Sarah. We'll come back to you, Stuart. I think you weren't picking up initially, but we're talking about shared information governance.
Yeah, it varies. I mean, we, with the area, we serve about 7 or 8 CCG areas, and 2 of those have got a very advanced kind of data sharing, information sharing agreement across all of the providers and primary care in that area. So that's really good to hook into. In other areas, it's not quite as successful. But one nice success that we have had is that the integrated neurology nurses, these community-based nurse specialists, they have got access to the hospital information systems and the primary care information systems and the centre's information systems all remotely via and accessible via iPad. So they're in a really, that's a real success for them. It means that they're carrying around loads of passwords, which is a bit of a challenge for them, but it's, you know, their role in connecting the patient pathway all the way through from home right through every level of care. They couldn't do that without being able to access the clinical information, the records that they need, and we have been able to get that in place.
Okay, thank you. Well, I'm delighted to welcome Jacob West, who's the National Lead for the Acute Care Collaboration model. Jacob, we've been having a very rich discussion about some of the models that the panellists are involved in. It would be really interesting to hear from you for a few minutes about your overview about the acute care collaboration and some of the particular challenges that you've identified.
Thank you, Charlie. Can I just check you can hear me?
Yeah, I can hear you very well. Thank you.
Great, and apologies for being delayed. It's one of the perils of being in a job that requires me to be around the country quite a lot. And thank you to all the panelists for taking part. I'll just offer a couple of words of initial reflection. I think what we've got with these set of vanguards is a really interesting set of experiments. For those of you who remember, the Dalton Review a couple of years ago set out some of the options for how organizations might collaborate in ways that would help address some of the variations in quality and some of the efficiency challenges that the NHS face. And in a way, what we've got is 13 linked but different experiments going on around the country. So I think our first test really is, and no doubt Sarah, Stuart and Tim will already been talking about this, is to be able to demonstrate that some of these new approaches are starting to deliver value. And that's, of course, that's a challenge because large-scale transformation takes time. But I think that's the sort of challenge number one. The second challenge, I think, is to try and identify in what kind of collaborative arrangement are you most likely to see those benefits? So, you know, what is it about Dartford and Gravesham and Guy's and Tommy's connection that might have lessons for elsewhere in the country? What is it about Tim's radiology consortium in the East Midlands that might have lessons for elsewhere? Because what we don't want to do with this program is to create sort of boutique solutions that work only for bits of the country. We want to try and test models that have wider application. You know, Charlie, you'll know this better than I, but we're good at starting things in the NHS, aren't we? We're not so good at sort of adopting them at scale. And then I think the third challenge is to work out, and sometimes people start with this, but to work out what precise governance and organizational form helps you to sort of lock that way of working together in for the long term. And again, we've got a variety of these on show. So the Royal Free, as you'll know, are looking at a group model. That's quite different again from Stuart's model in the Northwest with the Walton Centre. Moorfields have got a satellite service model with 32 clinics around London and the Southeast. Tim's model is a looser collaborative arrangement, and I think if you saw the introductory slides, you'll have seen some sense of these different models. We don't want to start with the governance and organisational form, but it is an important consideration. So I'll pause there.
That's great, Jacob. That's some very interesting insights there. What I'd quite like to do, because the models that have been created essentially predate the sustainability and transformation partnerships, and that clearly is likely to have an impact on many things, not least new models of care. I'd be really interested to hear from some of the panellists about how the creation of the STPs is having an impact on your work and what the implications might be as we move into a delivery phase for STPs. So, Junaid, didn't ask you the previous question, so I don't know whether you have any views about that generally before we move on to some of the other panellists.
So I suppose it's only a reflection, which is if one thing is definite in the system, it's change is a constant. Yeah. And if we accept and embrace change to be a constant, I think we should, if we look through how we can enable the STPs to deliver their plan through the learnings of what the current vanguards are doing, and then enable spread and scale through mechanisms that both AHSNs and STPs have, I think we'll discover the opportunities in the mix around what we can do moreover than some of the challenges.
That sounds like very pragmatic advice. Tim, can I ask you what your interactions have been and what your thoughts about how it might influence your plans?
Oh, they're a total pain. I mean, let's be honest about this. It's STPs have this fantastic thing. I cover 5 STPs in the MRAD collaboration, so you can imagine that we have a lot of fun actually trying to work out what the STPs know. The concept of an STP being that it manages a massive geographical area and multiple social and healthcare enterprises is probably the only one that's going to work. But I think it's very fair to say that just as we found our feet as a Vanguard, as an acute care collaboration, most of the STPs are still finding theirs. And to actually step into an STP and even find the right person to talk to and say, look, by the way, guys, we are doing this already, and it's very, very challenging. So I think the STPs are going to be the framework that we deliver services in, but in the same way as we might not engage fully with all of the other CCGs and SHAs before then, we just need to make sure that we're on the radar and that we can provide assistance and help if it's needed.
Yeah. Stuart, what's your experience today, and what do you think the implications are in terms of your delivery?
Right, well, we're fortunate with our STP in that the footprint is Cheshire and Merseyside, which is the same as our service.
Okay, that's straightforward.
And we were immediately adopted by the STP as one of the clinical themes. And that it's on the agenda for all the partners. And after this, I'm dashing off to give an update to the overarching STP program board on our work. So that's been quite positive for us. But the one thing we're also trying to do is there are some other services within service lines within the STP which are looking at different models, and we're looking to collaborate with them in terms of our learning about how we deliver our services through networks, and what we've been finding out through the Vanguard, and also through the learning we've had from other sites, talking with the likes of Moorfields, Royal Free and so on, about what they're doing to feed that back into other services and other specialties and pathways across Cheshire and Merseyside so that we get the most benefit.
Okay, thank you, Stuart. Sarah, what are your experiences and views on STPs?
So we span 2. We span South East London and Kent and Medway with Dartford, but so we'd had something running for a while called Our Healthier South East London, of which Dartford were a member. So when the STPs came along and Dartford went into the other STP, they were still named in ours to continue some of that good work. So we've been able to navigate it quite well. And actually part of it is thinking about it. We are included in both STPs. So how do we spread the learning that we've got actually around our governance arrangements? So how have we collaborated, and how can we share that learning, and how STPs might want to collaborate? Because I think for us, we don't think that people would necessarily want to join the group, but actually, and it might be similar to Tim, how we've come together, how we've created that trust, how we've created the collaboration to then accelerate clinical models could be something that STPs may be interested in learning that process, rather than say, well, you come and join the GST group. So there is something in that, how do you partner in when you're not necessarily the same, and that's been quite interesting learning for us, given the asymmetry between us and Dartford and as an organisation, how we keep that still feeling quite equal partners.
Yeah. But Jacob, I mean, I'm sort of interested, I mean, obviously in your national role, presumably you're having to have sort of multiple conversations, and I'm interested how you're sort of trying to sort of align STPs around sort of common areas.
Thanks, Charlie. I think STPs are clearly going to be here for the longer term. They're going to be a key organising principle. But I'm just reflecting, it seems apt today to maybe borrow a European piece of jargon, which is subsidiarity. And as I understand that, it means do the right thing at the right geographical footprint. And it seems to me that STPs aren't going to be the only geographical footprint in which you do business for any bit of our healthcare system. So that they are clearly going to be the right unit of geography for many activities, but not for everything. So in some areas, that's neater. Take Dorset, for example, where you have quite aligned coterminous geography between local health and care services. Northumberland might be another example. But in other places, it will be more complicated. And I don't think there's any intention, for example, behind the design of STPs such that if you have got the prospect of consolidating, say, your back office services or your pathology services over a bigger footprint than a single STP, that should be, in any way be held up. You know, the whole Carter agenda, for example, is about doing that at the right geographical footprint, at the right scale. Equally, we've got some of the vanguards who are going to be operating on a national level, and that will mean interacting in a meaningful way with multiple STPs. So I think I think King Fund described it as working as systems within systems. We've always got used to that in the NHS. STPs are just another version of that. We've got to be pragmatic about it.
Thanks very much. I think that was some interesting perspective from different points of view. The other area that I was quite keen to get people's views on is around the leadership within these organisations. I mean, I was involved in a discussion at the Royal Free yesterday about how we work across our group, and it struck me that for this to be successful, we really have to galvanise a new generation of leaders who really embrace change. And what I'm interested in is how you're doing that within your own vanguards, and equally, how do you get that to work across multiple organisations, particularly in traditional pathways where often clinicians, other health professionals are often stuck within one particular institution. Tim, is this something that you've experienced?
Yes. I think anybody who's tried to drive a change forward, particularly when that change is being driven in an uncertain environment and in a highly constrained service, would probably know that the easier position to take is the one that doesn't lead to change. Without very solid leadership, and I don't mean in the kind of hero single leader dragging everybody behind them, but without a body of people who have authority to make a change and have the belief that the change is the right thing to do, projects like this are very, very hard indeed. So my whole team are massively supportive, and often actually the greatest learning opportunities and the greatest experiences we have are when something goes wrong and we see senior leaders in our organisations supporting each other collaboratively in ways that just would not happen before we started this collaboration.
Yeah.
And that is so powerful. The NHS is full of good leaders who just want to do the right thing. And it's a privilege to watch them do it, to be honest.
It sounds like we need more publicity around that type of thing, because often we don't share that good type of behaviour about people doing the right thing and behaving well. Yeah,
I mean, it's genuinely, it's lovely to see my executive boards that meet in our consortium. Our board meetings every month are a joy to go to, because actually people sit forward, they engage, and they call each other out on behaviour. They call each other's organisations out, saying you're causing a problem to us, sort your act out, and they keep talking when the meeting's finished. And this culture of openness is absolutely possible, but it's built on a culture of trust. And we've lost that sometimes in some organisations, I feel.
Yeah. Stuart, what's your perspective?
I think I'd say I'd agree with what was just said. So much of it is about trust, and it's about personal relationships, and then through the good personal relationships, you can start to form a close working relationship between your organisations. I think one of the things that's been most interesting for us in our Vanguard has been, as a Vanguard hosted by a provider, trying to change a whole system and a whole pathway. We've been working mainly actually with the CCGs, and so from our point of view, it's actually understanding much better the CCG mindset, what their priorities, how they work, what their systems are. And we felt, I suppose, in a sense, a little bit humble about the lack of knowledge that we had of that. But we need to go about it in that way, because we can only make the change if we've got them on side and we're fitting with their agendas and styles and way of working. I think that's been it's a very different leadership kind of style. It's a much more sort of humble style to put your hands more in put yourself more in the hands of your partner organisations.
I mean, in your particular example, I mean, as a neurologist, I'm particularly interested because you're the only sort of neurology vanguard in the country, and having the leadership that you're developing, how do we spread that out across the country so that other organisations with other neurology models can benefit from that? I mean, I'm not sure which organisations or which mechanisms are best to facilitate that, but it strikes me as something quite important.
Yeah, absolutely, and it'd be really interesting to have a conversation offline about it, because there are different models and people get quite attached to their models, and what we're going to need to find is the right evidence and language and the right way of engaging with people to be able to spread that kind of learning. So the first thing, if you're coming to the Association of British Neurologists in Liverpool in May, then come and talk to us.
I will do, Stuart. Thank you for the invitation. Sarah, I wonder if I can change tack slightly in the interest of time, because obviously particularly significant interest around 7-day services across acute trust. How's your model helping to meet the challenge of 7-day services?
So I think part of the challenge of being a district general hospital is the feedback that we've been getting from people who have expressed interest is workforce and being able to, have the right number to do that. And so part of our model is looking at how do you have a single consultant body, so to speak, that works across the network. And so that's what we're doing with vascular and our proactive older people services, as I mentioned before. And what we've been in conversation with Health Education England about is how do we help with the training placements? Can we start to think quite differently about how we train more flexible working into just the way we work? Because actually all the institutions trying to do it all just by themselves is going to be very, very difficult, and we don't really have the workforce that's going to do that. So how do we collaborate and work in partnership, and how do we create that as an expectation going forward as how we work? Because my personal view is I don't think we're going to be able to deliver it if we don't start sharing our scarce resources much more effectively, and that's part of the principle of what we're trying to do. And just to reiterate the virtual element of that, so MDTs, access to specialist opinion and things that do help clinicians to actually deliver safe care on the ground without having to refer it and make better decisions.
Yeah. I mean, I guess that's like the 7-day services is closely linked to the whole aspect of workforce shortages, which in some specialities are a major issue. Jacob, is that something that's coming out across many of the acute care collaborations around workforce shortages and delivering?
I would turn it round, Charlie. I think lots of what I'm hearing, and Stuart, Tim, Sarah will be able to speak to this, is that these collaborations are emerging in part to try and address, among other things, issues of workforce scarcity. So, Tim's got a model in the East Midlands which tries to make better use of that scarce, expensive resource, which is the consultant radiologist. Yeah. So, Sarah in the South East is looking at how they use their consultants in paediatrics and other specialties across a bigger footprint. So I think these collaborations they won't be the full answer, but they are a response to that challenge.
They're part of the solution. Well, Tim, it'd be interesting to hear from you then about how you're managing to answer that challenge.
We're not. The challenge is huge. Particularly in my patch, let's be clear. I've got millions and millions of pounds worth of stuff going out of NHS organisations and getting service provided by third parties. I've got massive recruitment and retention issues across all of our patch, with job vacancies running between 30 and 50% in some areas. There's nothing that an acute care collaboration Vanguard is suddenly going to wave at this which will make it better, but what we can do is make it more attractive and support people. So to find the shortage specialties, to find the areas like paediatrics where there's never enough people, and to allow those services to be provided from one location into another, stopping patients having to move around, and allowing small DGHs to continue the absolutely crucial work that they do in keeping communities together and keeping patients healthy. That's what we're trying to do. The challenge is that it requires a change in mindset from some of the larger organisations. Certainly the big tertiary centres in this sort of acute care collaboration model find themselves, instead of taking work from small organisations, they actually need to reach out into those small organisations and support them. That's sometimes hard in an NHS business model that is designed around the bottom line. And so that's really hard.
Thanks, Tim.
And so can I just come in on that? And actually, Tim, that's exactly what we've been trying to do. But actually what's been quite interesting is the media have had quite an interest in that, and it's been seen as, actually we've been taking resources away from our own population, which of course isn't true, because the patients would have travelled to get the care. So it's how do we get that messaging right, I think, in terms of why we're doing some of these models and how beneficial they are for a broader population of patients as well, which I think has been an interesting challenge for us.
Yeah, the challenge between what's right for a patient population versus what's right for the person in front of me is really hard, and sometimes that square I don't think can be turned into a circle. It's just a tension that we have to live with.
Can I ask, before we finish, I've got one final request of the panellists, and a very brief reflection on what you've learned. What would you say is the biggest learning? Junaid, can I start with you? In terms of your involvement with Vanguards, what's your one reflection?
So they've all been on a journey, but the journey continues, and it's going to be around for a while. But the trick is going to be around trust across the silos of the NHS, to put the patients at the heart of what they're trying to do and deliver care around the needs of patients.
Thank you, Junaid. Sarah, can I ask you if you have one final reflection on what you've learned?
So I think the investment that we've done in our relationship with Dartford, and then spent time actually really thinking about what is it we're trying to achieve here for the broader population, and the vision that we've got. We've got a vision picture that outlines that, has really paid off, because you can go further faster once you've put the groundwork in at the beginning, but it takes a lot of time and effort and will, I think.
Okay, thank you. Stuart?
For me, I think it's the time involved in doing it properly. We started off with some ideas which we could have just ploughed on with, but really to make them work properly, it's about the co-production and the relationships that we need to form with the acute hospitals and PGs and primary care, and it takes time to do that.
Yeah, absolutely. And then in one sentence, Tim, what have you learned?
Transparency brings trust.
Okay, I like your conciseness there, thank you. Jacob, one reflection very quickly.
I think we're starting to see from the other Vanguards, the MCPs, PACs and the care homes, that you can have an impact when you put focus, effort, resource into these kind of experiments. So we need to hold our nerve as a system and give these guys and others space to continue their journey.
That's great. So I'm going to ask people now to give an index about how much they feel they know about the Acute Care Collaboration Vanguard, having listened to that really rich discussion from the panellists. So if you can enter that on the slide now using the arrow. And we're going to send out an evaluation email. If there's any questions or if anyone hasn't been able to join, can listen online later. There's a link in the chat box to that now. Please continue tweeting with your views and reflections in the future, #FutureNHS. And thank you very much for your contributions and goodbye.
Thank you, bye.
Bye.
Thank you. See you guys. Bye.
Thank you, everybody, for that wonderful session. We'll just wait for a number of